All right. Good morning, everyone. I have 7 o'clock straight up, so we're going to go ahead and get started. Good morning. My name is Melody Bachenfeld, and as co-chair of the DEI committee, I have the honor of welcoming back Shiva Badar-Siloff and Naomi Takahashi. Shiva is the Vice President and Chief Diversity Officer at UW Health and an appointee of the newly formed Governor's Health Equity Council. And Naomi is the newly appointed Director of Diversity, Equity, and Inclusion at UW Health. They've been a tremendous source of leadership and guidance to our department in our DEI efforts, and we are so excited to have them back this morning for this bystander intervention training. So I'm going to stop. I will add the text code into the chat box, but for those of you on the phone, the code for today's session is JEVHAQ.
So glad we're having this session, and I asked Melody to introduce our two speakers because Melody is doing a tremendous job with me as co-chair of the DEI. So take over, guys.
Good morning, everybody. Thank you so much, Melody and Dr. Rice, for allowing us this time this morning to talk about addressing microaggressions in healthcare. And thank you specifically for your leadership in the diversity, equity, and inclusion space, which is such a critical work for us as an organization, now more than ever, I would say. So Naomi and I will be covering a number of areas of microaggression this morning. So we're first going to just very quickly review again our commitment to diversity, equity, and inclusion at UW Health. We'll spend some time defining microaggression, what they are, how do they show up in our environment, and then talk about our resources, policies, and tools that we have to interrupt microaggression when we witness or experience them. So first, again, a quick overview of our commitment as UW Health to this issue. One, back in February of 2020, both Dr. Kaplan and Dean Golden made a very strong statement around our commitment as an organization to a diverse, equitable, and inclusive environment. I'm very specifically talking about the fact that we, as an organization, do not have any tolerance around any behavior in the organization that is bigoted behavior, racism, xenophobia, homophobia, transphobia, sexism, prejudice, and intolerance are the words that are used in their statement. This is actually a statement that was made to also support a policy that we will talk about later in this morning around our patient discriminatory behavior or requests. So again, a statement that really sets the stage for what our values and expectations are within our organization. Next. There is also a statement that was made by Dr. Kaplan on June 2nd, right after the murder of George Floyd, talking about our commitment as an organization to anti-Black violence, condemning anti-Black violence and racism in our country, and really moving to being an anti-racist organization. And that we have a very, very important role to play, both as a health system providing healthcare in our communities, but also internally to our staff and faculty in making sure that we live up to our values of anti-racism.
So we also wanted to make sure that we obviously centered this conversation around the definition that we're using when we think about microaggressions. I think that sometimes microaggressions are misinterpreted as something similar to bullying or, just sort of everyday things that happen to everyone. And microaggressions are very specific because they are the sort of everyday slights, indignities, put downs, and insults that folks who are historically marginalized, so that is Black, Indigenous, people of color, women, LGBT populations, etc. So specifically historical marginalization is key to defining microaggressions. And these happen on a daily basis. So, they are sometimes unintentional or indirect, which makes them really difficult to name or identify, because oftentimes people can sort of say that there's an alternative reason as to why they occurred, which again sort of minimizes the experience of the person that is kind of addressing or saying that this happened to them. They often represent our unconscious beliefs or biases, and thus they're actually the behavioral expression of unchecked bias. So when we don't understand where our unconscious biases come from, that's when we can kind of act out in this way that becomes a microaggression. So really important to sort of identify that this is the impact of historically marginalized folks and their experience. So this is a variety of different ways that microaggressions show up, and these are based on racial identity, again, because we have heard ongoing, and sort of the basis of this policy that we'll talk about in a little bit is also related to the experiences of Black, Indigenous folks of color within our organization. And so these are kind of an accumulation of different microaggressions that people have shared with us, that people in trainings have shared with us related to race. And I think I share these because they're so common. And so if you notice something coming up for you, if you've, experienced these yourself, or you've noticed something that you may have done before, that's a part of this work, is really recognizing, and we'll kind of revisit the growth zone that we did last time. But these are ways that we sort of notice these things coming up, and that's why it's important that we are able to identify and name them. The first one is being ignored or not being greeted or stopping conversation when a person of color walks into the room. This has been time and time again, we've heard this, of folks just noticing a difference in people's behavior, a lack of engagement, a lack of sort of conversation because, and definitely related to their race. Another one is tone policing. So an example of that is using tone as sort of a deflection. Oh, your tone like that, when you talk to me like that, I can't understand you, or people don't receive you well when you have that tone. You always seem angry over nothing. You're making a big deal out of nothing. So again, sort of like talking about a person in relation to their tone rather than sort of thinking about what they're bringing up or why they're coming to you. Touching someone's hair without asking to see what the texture feels like. This seems like a shock to some people because nobody's actually, some people have never had their hair touched inappropriately, but this happens to especially our Black colleagues very, very often. You don't talk like you're blank, or other comments about ways of communicating. So sort of making comments about people's way of talking. Oh, you sound so eloquent for, for a person of color, or I didn't think that you'd sound that well-spoken, etc. Mispronouncing a person's name after being corrected, or not bothering to pronounce the name correctly in the first place. We know names have a lot of sort of cultural connection and experience related to them, and a lot of identity is kind of wrapped up in our names. So when we are mispronouncing a person's name or shortening a person's name, or when they tell us how to pronounce it and then we just avoid pronouncing it or continue to say it wrong, that shows that we're not really engaged with the person. We don't actually care about pronouncing their name correctly, and that part of their identity is sort of misrepresented. So being really mindful about how we practice. There are a lot of different names out there, and I think one of the best things that we can do, especially in healthcare, is practicing asking the person again to say it slowly for you because you want to pronounce it correctly, and really putting in the work ourselves. Asking invasive questions about someone's ethnicity or racial identity. I think the rule here is always just, am I willing to answer those questions, and do I have a relationship with this person where asking those questions makes sense? We often ask questions because people's racial identity or background is maybe confusing to us on the outside, or we're curious, and those are not necessarily reasons to ask. And so I think a good rule is just remembering, do I have a relationship with this person? Because I think, especially, from my own experience, sharing about my racial background is something that I love doing with people that I feel I'm in relationship with. But for strangers, it's not something that we necessarily want to be sharing. Tokenizing or asking a person of color to speak on behalf of their entire racial group. So, I think this is pretty straightforward, but I think this one relates to the last one as well, which is the us versus them. So folks of color are sort of always looped together as a group of people, and white people get to be individuals. And so we see this a lot, like where even in classroom settings, where people are asked, tell me your experience about this, to the only person of color in the room. And that, again, is, asking them to speak on behalf of an entire racial group of people. Another one is you act more blank, you aren't really blank. So again, sort of making characterizations or stereotypes about a person based on their race. Assuming a person can only hold a certain title or role or got a job because of their race. Saying you treat everyone the same no matter what their racial identity. This is the same as using a colorblind approach or saying you don't see color. We just don't treat everybody the same, and we cannot. I don't treat my mother the same way that I treat my partner or my child. And you wouldn't treat your patient the same way that you would treat a family member. And so, I think this is really goes back to this idea of equity, is that we actually treat people differently based on the identities that they hold, the relationship that we have with them. And so it's really important to not minimize that racial experience. And not say sort of this sort of overarching equality approach in terms of especially care and how we interact with each other. And then again, referring to folks of color as a group and white people getting to be individuals. So these are just some examples of how microaggressions show up, specifically related to race. I just want to remind folks to mute yourselves as you come in. I'm noticing a little bit of background noise. Thank you. So the question that just came through on the chat is, do you have to be historically marginalized to experience a microaggression? Absolutely, yes. So that's a part of the definition of a microaggression, is that it's specific to being a part of a historically marginalized community. So microaggressions are very specific. People can have prejudice against people, and microaggressions have a lot to do with power that's associated with how we in society, especially related to race, related to gender, give certain power to certain people. And so if there's power within that relationship and that looks different, that plays a role in sort of how these are experienced. I also want to say too that that's really important in healthcare as well, because roles also play kind of a part power dynamic. So if you are in a provider role versus a medical assistant role versus a patient role, that power dynamic is also a part of what is happening in the room. Not to say that, a provider of color cannot experience a microaggression. They absolutely can. But in terms of the impact and how it plays out, also roles are very important, especially in sort of our tiered healthcare system. So, I think I'd like to just have you all think about this, of how you've seen microaggressions show up. We're not going to really engage in conversation with this right now, but I've shared some examples, and I think it's really important just to be thinking about these things as we kind of move forward. All right, so this is some of the ways that we've also had it shared with us that microaggressions are manifesting in healthcare. Sort of in a more individual or micro way, we're seeing this as racial profiling and how that shows up, especially in terms of how people get medication refilled in the pharmacy. So I don't know if this ever happened to you, where you go in and you call and you say, hey, I need a prescription refilled. And then they look and they're like, oh, you're out of refills. And then they're really kind and generous, and they help you get those refills done in a really quick amount of time by contacting your provider and sending the script in. So apparently there's been a lot of research actually around how this is very different if you call and your name sounds foreign, or you have an accent, or you go in person for the refill and you are a Black, Indigenous, or person of color. So that experience means that this person is given a harder time to get prescription refills, which we know absolutely impact the way that people's care is being provided. We also see racial profiling in terms of the second piece, which is differential treatment by security in hospital or clinic settings. So when people enter our hospital, they're being stopped at much higher rates if they're Black or Indigenous or a person of color versus folks that are white. And this is true for, we know, our providers as well as any other staff that's coming through regularly, as well as patients. And so this, again, is based on sort of whoever is stopping the person's assumptions and stereotypes around whether or not they're supposed to be in that space. Biases towards, non-English speaking, low-income HIV positive patients. We see this a lot in terms of healthcare and how people are treated. This also is connected to this kind of two down, which is how informed consent is being communicated. So we actually did a training for the birthing center nurses, and they were speaking about how they've noticed how sometimes when they're observing that they have seen how informed consent actually gets communicated for different patients, depending on whether or not they're seen as English speaking as a, primary language, or they're English as a second language speakers, or they have accented English, or they're using an interpreter, that informed consent seems to be quicker and less detailed. And so that goes back to years and years of our healthcare system building distrust, especially with communities of color, where informed consent was not being given. And so, that this is happening, and we're hearing about this happening is a big concern, of course, because this is the rights of patients to really be informed about the treatment that they're getting. And so it's simplified or not given in the same way as it would for somebody who speaks English fluently. And I'm going to jump back up to differential treatment in the emergency department or the NICU. We've heard a lot of stories about, especially within the NICU setting, of babies, Black babies specifically, being treated very differently than white babies based on the way in which care is being provided, the kinds of support that the caregivers are being, or parents are given, and just general sort of overall connection and, I think, attention, which we know early on. And I mean, I'm speaking to all of you, you all know this just as well, as how important those early moments are. And so we've heard stories of, the, nurses coming to us and saying, we're noticing that there's a difference in treatment here, and that really being a connection to seeing how, ongoing sort of wellness and health looks like for those babies. And of course, we know we have racial inequities in low birth weight infants in Dane County. So Black mothers are predominantly, we're higher risk of giving birth to low birth weight infants, or infants who die in the first year of life. And this is very much related to the racism that they experience, not only day to day in their daily lives, but also as they interface with our healthcare system. And then we're seeing a lot of racial inequities with COVID-19 deaths, and this is very much related to that last video we shared last time in our anti-racism discussion around, biases that folks of color are experiencing when they interface with the healthcare system, and how that really impacts whether they or not they get the care that they need. And then, of course, increased depression and suicidality as well in terms of mental health care. So the impact is, at the individual level, we see this as all of things. And I want to draw attention to this sort of heightened reactivity. So when somebody's experiencing microaggressions and in an ongoing basis, day to day, sometimes the same ones over and over again, that there is this sort of level of reactivity that folks have to it, and rightly so, because it's very harmful. Sort of like we see it as, and maybe you've heard about this before, but a cut being done in the same exact place, a paper cut, over and over and over again. Maybe the first paper cut doesn't hurt, but if you've had the same paper cut since you were a child and it continues on into your adult life, that it becomes a sort of like gaping wound that only you can see, but that you carry with you as you continue. And so those are really important things that we're seeing. And of course, all of these things at the individual level are very much connected to health and wellness. And at the organizational level, we see it in these ways, which is obviously against sort of a lot of the things that we value in terms of creating a more inclusive atmosphere and culture for folks and making it a more anti-racist culture. This really violates the core value of who we say we are as an organization. We see this in low retention, poor engagement, low morale, distrust, right? All of these things that really harm people and can continue to harm them in terms of the workplace. So next piece, I'm going to share this video clip, and then she was going to kind of talk about policies. But this video clip is from the University of Chicago, and talking about a similar policy that we have in place, and sort of the why of how it came about, based on the experiences that they're sharing from this one specific doctor. So we'll watch this and then talk about policies.
Dr. Monica Peak was the attending physician for a patient with a serious condition. The patient refused care from Dr. Peak and her team and issued a written request for a white physician.
That the primary thing on his mind was not his health, but his racial prejudices towards persons of color who are caring for him. It was August 1st.
It's an open secret. Credentials don't protect physicians of color from experiencing racism. And there isn't an official national policy to help doctors deal with patient prejudice.
Did that catch you by surprise when you first saw that complaint?
It did not catch me by surprise because, again, I've had experiences like this throughout my life and throughout my career in medicine, starting as a medical student. But it was disappointing.
A recent study found that 6 in 10 doctors surveyed had experienced some sort of biased remarks from their patients about their gender, ethnicity, race, age, or weight. About 16%, or 160,000 physicians in the U.S., are Black or Asian. And yet the study found the majority of them are targets of patient prejudice when compared to other physicians.
You can't go to a restaurant and say, I don't want to be served by any, Latino waiters. That would violate Title II of the Civil Rights Act. So I thought it was odd that here we have in the medical context this happening all the time.
It's called informed consent, when patients learn of their condition and give consent to a doctor for treatment. Patients have the right to refuse care by a physician, but what if a patient refuses care due to bigotry?
I've been an African-American woman my entire life, and so experiences that I've had as a physician with racism are not entirely different than experience I've had as a regular person with racism.
The patient was transferred to the intensive care unit, the ICU, not because of his complaint, but because of the severity of his illness.
The white coat, the hospital walls, they don't protect someone from racism.
Mm-hmm.
How does it impact physicians, or more specifically, how does it impact you?
It has been one of the greatest joys of my life being a physician. Can we pause?
The New England Journal of Medicine says for minority healthcare workers, patient expressions of racial preferences are painful and degrading and can contribute to moral distress and burnout.
Have you ever wanted to stop being a physician?
It has never occurred to me to stop what I'm doing.
Good. Good.
Life is full of challenges. I know the road that is behind me, that my foremothers and fathers sort of fought to pave the way for me. And so my road has certainly been easier than people who came before me. My road will hopefully be more difficult than those who come behind me.
The article, co-authored by Paul Emile, aims to help physicians deal with discriminatory patients. Its flowchart offers options for moving forward with care. For example, if a patient request is bigoted, the chart suggests options to accommodate, transfer, negotiate, or limit unacceptable conduct from that patient. Paul Emile admits that a request to be reassigned to another physician isn't always discriminatory or racist.
It might look like bigotry, something else. So, for example, it could be that the patient is a war veteran, and the physician reminds them of a former enemy combatant. in situations like this, it could be bias, but it could also be PTSD.
The bigger, more important issue is what happens when patients are the target of racism. Structural racism, interpersonal racism, because they're the ones who are sick and vulnerable entering the system and really need help. All right, let me just take a quick listen to your chest. Lungs sound great. And the problem is not going to be solved unless we all roll up our sleeves and get to work. So that's every person. That's every white person. That's every straight person. Every person.
Thank you. So as you saw from this video, the issue of discriminatory remarks or requests by patient is something that has been a subject of a lot of conversation and perspectives at the national level as far as the policy is concerned. But as far as the lived experience of our, again, physicians, specifically our faculty of color, this is an experience that they have expressed and have described as their lived experiences for a long time. So we at UW Health have wanted to make sure to have the appropriate kind of structures and policies in place to be able to clearly describe the values that we hold as an organization and also provide the protections that policy can provide for, again, both our faculty and staff and our patients around discriminatory behavior. So there are a number of policies that really address these issues. We will be talking a bit more about the first one, which is the last policy that we actually have adopted as an organization, which is the patient and family and visitor discriminatory requests or behavior. But I do want to make sure to mention that there are a number of other policies that come into play when we are dealing with these type of discrimination and bigoted behavior. So the patient rights and responsibilities, it's a document and a policy that really outlines what the patients have as rights. Those rights of patients are part of requirements that we have from the federal government and CMS. So they're really prescribed to us as rights for patients, as also are the responsibilities of patients. And again, really important to point out that patients do have rights, but they also have responsibilities. And one of those responsibilities, broadly expressed, is respect of our providers and staff in their interactions with them. We do also have a policy that's around disruptive behavior. Again, disruptive behavior can be around a lot of different issues and reasons, but we also know that sometimes patients engage in disruptive behavior that finds its root in bigoted or racist behavior from the patient. So again, that policy outlines the actions that we need to take if the patient is actually engaging in disruptive behavior. Around our employment and protection of staff, we of course have an equal employment opportunity and non-discrimination policy reflecting the federal requirements for that. We have also put in place a number of policies that really reflect our values around being an inclusive place and space for our LGBTQ plus communities, both, again, physicians, staff, and patients. So we have gender inclusive policies as an organization. We have guidelines for professional conduct of physician faculty in the clinical setting, workplace violence reporting and investigation process policy, and of course a grievance process specifically here for residents related to employment concern and issues that they may experience in the workplace. So again, number of different policies. I'm not even mentioning all of them, like the informed consent policy is another one that comes into play when we talk about the actions that we need to take when patients are engaging, patients or family members are engaging in behavior that we do not want to condone. Next. So now talking about our UW Health patient and family and visitor discriminatory requests or behavior. This is a policy that was adopted in July of this year after over a year of work that was put into really trying to frame this policy and the actions that we can take as an organization. And I want to make sure that we stay centered in the purpose of this policy. The purpose of this policy, again, is to ensure safe, timely, culturally competent, and quality patient care while protecting staff from bias, discrimination, and disrespect. And again, the policy and the reason that we moved into having a separate policy around this is to center around historically marginalized faculty and staff, and the many stories that we were hearing from faculty and staff around microaggression and around just pure discrimination and requests from patients that were very directly bigoted and really reflected racial discrimination on the part of the patient. So the policy is really centered around the protection of, again, those faculty and staff that have historically been the subject of many discriminatory and bigoted behavior by patient, family, and visitors. Next. So, and we'll have a bit more time to talk about the policy itself, but I do want to say that the policy really, whenever there is the time and appropriate ability to do so, directs faculty and staff and managers in the clinics to involve patient relations and really have patient relations be that key communication link with the patient and family members about their behavior. Just like patient relations is that kind of key link with patients and families around any other issues that come up in our environment. So it's really important to remember that patient relation has a role to play also around patient and family discriminatory behavior. So they are the key department to go to try to address the concern, to discuss next steps with us internally as, again, physicians and staff, and then to discuss then the next step that we'll be taking with patients based on their behavior and also based on regulatory requirements that we have regarding patient rights. I want to mention this because specifically for our physicians of color, it's really important to know that there is a support department to really take on this communication with patients and families. Because as people of color, really having to endure the discrimination, but also having to really have the burden to take all the additional steps becomes really in itself a huge burden to carry, and part of the burnout that we often hear our faculty of color go through. So they're there to really provide that support. I want to make sure that you all know that we work very closely in our department with the patient relations department when the issues that are raised are around patient discriminatory behavior. So we discuss collaboratively how to address it, what the next steps are, and work in tandem in providing support both for the faculty and staff that have raised the issue, but also in how we frame and respond to the patient or family member. Next. So the staff and provider assistance in this challenging situation, again, involves either consultation on planning. This is going to be mostly applicable when the situation happens in an ambulatory situation, where there is, again, more time to really be able to address the patient's behavior. and set up a plan going forward with that patient and family about what we're going to do as far as their care. So that is available. There are behavior expectation conversations and letters that can be sent to patients, and all the way to no further service process. And important to know that we have, based on the patient's behavior, we can move either quickly to a no further service. It can be immediate because the patient's behavior is really egregious, or it could be, a warning, this is not acceptable. If you continue to engage in any of this behavior, we will move into a no further service. So again, we have a continuum of ways that we can address the patient and family's behavior. There is also the disruptive event consultation that is available when the situation is within the hospital. Certainly, we can also use either the disclosure of unanticipated events, or we can also use our patient safety net to report these kind of situations and behavior by patients. And of course, we, in our conversations with patients and family members, always go back to talk to them also about the patient rights and responsibilities that are really important in their behavior within our house and within our walls, and what our value expectations are of them. Next. This, of course, looks like a super difficult thing to read, but we wanted to make sure that you're all aware that the policy has two supporting documents to it, and the supporting documents are intended to just provide additional guidance in how to engage in decision making when the patient engages or family engages in, again, behavior that is bigoted or discriminatory towards our providers. So it really, just like you saw in the video, and just like we've seen in best practice in other organizations, provides kind of some decision-making points in how we make decisions about dealing with the patient's behavior. And most of that has to do with whether the patient is one in an outpatient ambulatory situation, to whether the patient is from a medical perspective in a stable or more urgent need and situation. Next. It also has a supporting document that's called the key responses document. This is the tool that I think it's really, really important for everybody to really pay attention to and try to honestly practice the different key responses. What we see most often is that the patient makes these comments that we're not really prepared and don't know how to respond. And we, I mean specifically others than the person who is receiving the microaggression. Those are the bystander is the key person to really provide this responsive if a bystander is available and can do that. So if, for example, it is a resident that is a subject of the microaggression, having an attending is available, having the attending go back in and really address the issue with the patient is really important. So here is some, again, key responses that we can use. And the reason that we have them as kind of elevating is because things can be a microaggression at a level that, again, for those of us who are people of color, we hear this probably 10 times a day. So it's things like, what country are you from? Your accent is, and being able to just simply respond very quickly to say UW Health is committed to being a diverse and inclusive environment for all. I can tell you that as a person that gets this comment very, very often, just that quick response sends the message to the person that made that comment that their comment is not appreciated and that I'm not going to engage further in that conversation. So people really quickly understand what you're saying as by just responding that, like, you know, your accent is, yeah, at UW Health, we're really committed to being a diverse and inclusive environment, and it stops the conversation. At the next level is, you know, things that start becoming really much more problematic in the comments. So I'm calling them macroaggression, but I don't like, and you can fill in the blank. Responses, again, that can be some key responses. My role is to take the very best care of you. We are here to help you as a team. We do not change doctors based on, and you can fill in. So again, being ready and prepared to be able to give those kind of responses is really important. And then we move up in starting to really implement additional tools from within our policy that are around bigoted comments, around requests that are bigoted. And again, the policy needs to be implemented based on what situation you find yourself in, whether it is an emergent situation in labor and delivery, or whether it is a situation that is in an ambulatory setting where there is more time. Let's say somebody that's calling in to set up their care within a clinic. And then if it turns into really becoming a disruptive situation, and we move into using our disruptive patient behavior policy. And again, even within the disruptive behavior, I do want to make sure, and I know all of you that our physician understand that the disruptive behavior of the patient also needs to be put within the context of their medical condition, both as far as their how stable they are and not stable, as far as what we can do at that point in time, and also around their mental stability. Now, regardless of whether the patient is having disruptive behavior or using terms that are really extremely problematic because they maybe have dementia or just had a traumatic brain injury, the impact of those words and that behavior is still a very high impact on our Black, Indigenous, and people of color or other marginalized, historically marginalized individuals. So I do want to say that there is a side of it that is, what do we do to deal with the behavior of the patient? But at all times, we need to really understand that the impact on the person on the receiving end is still a very high impact, regardless of the patient's the reason why the patient is behaving and using the words that they're using. So we want to also make sure that we have in place ways to support the providers and staff at all times. And we are working very diligently as a department of diversity, equity, and inclusion to increase our capacity in being able to provide that kind of support. And I know that Dr. Rice and Melody and the DEI group have also been talking about, how do we create processes and an environment in which our providers can have the support to have somebody to talk to feel that they can openly really express the challenges that they went through by receiving the support quickly within the organization. So that may look like peer support within UW Health. At Merida, for example, they have a code Lavender, and that may look like being able to involve those kind of systems for discriminatory behavior, as we would involve them for other issues that need kind of peer support and debriefing. I cannot say strongly enough how, for those of you who are faculty, how important it is for you to be present and able to provide this kind of support for your residents and fellows. As we diversify our residents and fellows as an organization, we also need to make a commitment that we're going to be again present to support them as they absolutely have a sense of being within organizations that are predominantly white organization, and need to make sure that they do have their faculty available to debrief and provide them support as they receive this kind of microaggressions on a very regular basis. And I would say that most often we hear from residents and fellows around these experiences. And I see in the chat that there are mention about having posters for staff. We actually do have posters. So we printed them before, right at the time of COVID-19, and they've been sitting in a box in my office because I haven't been able to distribute them. But Melody, if you let me know where I can send them, and then you all can decide where you want to post them, we would love to get these key responses posters out and about. And I think there is another comment about making them into some form of cards that you can carry, or maybe even put behind your name badges. And that's a great and brilliant feedback. So we'll work on that and see if we can turn them into something that can be carried. Next. So the back of actually the key responses document has also some key ways of interrupting microaggressions, and we've purposefully kind of made the middle of it the most important, because the middle is when somebody witnesses a microaggression or was told about a microaggression. So it's really that bystander, that ally or co-conspirator role of being able to really be the person that steps in on behalf of the person that is receiving the microaggression. So really the most critical role is to really learn that role of bystander if you are not part of the historically marginalized groups. So really stepping in by talking to patient and visitor, by addressing their behavior, and by reminding of the policies that we have in place. And following up to, for example, say, we're going to be, I'm going to be contacting patient relations on behalf of, again, my coworker that was the subject of this macroaggression. I am going to be the one providing the support and listening, and just being able to, again, be present and listen is really important. Advocating for additional resources and advocating for the follow-up actions to be taken on behalf of the person that was actually the person receiving the discriminatory or bigoted remarks or behavior. Next.
All right. I also wanted to make sure to mention that this had come up in a couple of other trainings that we've done on this policy, is this first ask a question piece. So somebody said, what if you're not sure if the comment is bigoted or is a microaggression or not? And I think that's just the first piece, right? Is really digging a little bit deeper into why, sort of the basis of why the comment was made. So asking those questions, like, what do you mean by that? Or requesting this kind of provider, what are your concerns with current provider? Or I think that is a really important piece around getting to the root of why somebody is making a request, because like they said in that video, there can be requests made that maybe are not based in bigotry, right? So they might be based in trauma, they might be based in, cultural concordance of care. There might be other reasons why somebody is making a request. So we also wanted to share, because of sort of that highlight around bystander intervention. I think about the last training that we did together around anti-racism, and really a really important piece of that is thinking about acting now, right? So, I think about this being a really powerful opportunity to really interrupt when we see microaggressions happening, and not to sort of stand by and walk away anymore, or just end the situation and not follow up. So we've heard that as well, where people are saying, I just removed the person from the room, the staff member from the room, and then that was it. And that's not the way that we want this to be dealt with. We really want people as bystanders to intervene, and just like Shiva was saying, follow up. That's really important, is that what we've heard is that, our Black, Indigenous faculty and staff of color are feeling unheard, unsupported, and that needs to stop now. In terms of all of the allies or co-conspirators that we are, is to step in and to really do something. And I think part of it is that this example here of this strategy that Dr. Joy DeGruy talks about, and so she is the author of Post-Traumatic Slave Syndrome, and she talks about like this experience she had as a Black woman of her sister stepping in, and sort of the power of that bystander intervention. So I want to share it. I know it's a kind of a community-based example, but still very powerful, because I think we can do this not only in our workplaces, but also in our daily life.
My sister-in-law, who's half Black, half white, but looks white, blue eyes, whiter than most white folks, very white. She and I, we kind of grew up together. We raised our children together. So they're first cousins, and it's a wonderful, very, very multicultural family. So we're going in a Safeway one day, and Kathleen, my sister-in-law, is in front of me, and she's, writing a check for her groceries. Now, my daughter, who at the time was 10 years old, was standing with me, and I was directly behind her, getting ready to get my groceries. So Kathleen comes up, and the checker, who's a strawberry blonde, um, freckled, very delightful, warm, the checker, this young woman, is talking to Kathleen. Hey, how you doing? Isn't it a nice day today? They're just chatting up, and says, yeah. So Kathy writes her check, and she steps off to the side with her groceries because she's waiting for me. Of course, again, Kathleen looks white, right? So I come up, no conversation. She looks up at me, absolutely no, just a little chatter. And I write my check. My daughter, however, is 10, notices immediately the difference in how she responds to me. So I write my check, and she goes, I'm going to need 2 pieces of ID. At which point, my daughter looks at me, and she gets very, very embarrassed, and tears are kind of coming up in her eye, like, Mommy, you're not going to let her do this. Why is she doing this to us, right? So I'm trying to figure out what I should do, because behind me are 2 elderly white women, right? And I'm thinking, okay, so then I become the angry Black woman, right? And they're going to be, and I'm just trying to second guess all the drama. So then I just give her the 2 pieces of ID. I said, some things you got to choose your battles, right? And then it gets worse. She pulls out the bad check book, right? So this is the book that shows the people who've written bad checks. So she starts searching for my license in the bad checks, at which point it's just out of control now. Just as I'm standing there trying to decide what to do, and it's really deeply humiliating. Now my daughter is in full-blown emotionally upset, who's 10. My sister-in-law walks back over. And she steps in and she says, excuse me, why are you doing this? And the checker goes, well, what do you mean? She goes, why are you taking her through all of these changes? Why are you doing that? She goes, well, this is our policy. She goes, no, it's not your policy because you didn't do that with me. Oh, well, I know you've been, she goes, no, she's been here for years. I've only lived here for 3 months. And so at this point, the 2 white elderly ladies go, oh, I can't believe what this checker has done with this woman. And it's totally unacceptable. At which point the manager walks over. So the manager walks over and says, is there a problem here? And then my sister-in-law again responds, she goes, yes, there is a problem here. Here is what happened. So you see, she used her white privilege. And even though Kathleen is half Black and half white, she recognizes what that means. And she made the statement. She pointed out the injustice. And she, as a result of that one act, influenced everyone in that space. But what would have happened? I can't know for certain had the Black woman said, this is unfair. Why are you doing this to me? Would it have had the same impact? But Kathleen knew that she walked through the world differently than I did. And she used her white privilege to educate and make right a situation that was wrong. That's what you can do every single day.
The really powerful piece about that is sort of the power of the bystander being able to really step in and utilize their position, role, privilege in that space. And I think that is something that we really want to encourage folks to be doing when you're not somebody who has been a part of or on the receiving end of a microaggression. Is to really be that person that really steps in and vocalizes, right? This is not okay and this is not acceptable here. And using some of those strategies that we shared earlier in terms of responses to do that. I think about what she says in this video too around what would have happened, right? If she had stepped in herself, would it have had the same impact? Probably not, unfortunately. And so I think about that too, is that, that is the power of the bystander, is it can really change and the culture and the behavior and the expectations around it. And, I think as bystanders as well, it is not an easy thing to do, to step in and halt it. The easier thing to do is to pretend it didn't happen or to kind of move on and, hope that it ends. And I think that's something that this new policy is really hoping to elevate, is the importance of that we're done doing that now, that we've made a commitment to really halting any forms of bigotry and discrimination, and we have a responsibility to our colleagues, but also to our patients, to say that this is the way that you behave when you come into UW Health in our system. I wanted to bring this back up because we talked about this last session in terms of our growth zone. And I think this is a really key thing to think about when you think about your readiness to step in. I think oftentimes we expect comfort, right? We expect that if we're going to be uncomfortable, we don't want to do it. We don't want to step into that space. Or that stepping in and interrupting a microaggression might be a panic zone for us. And I think that that's really important work that we all do, is think about the situations that you're kind of feeling highly unnerved or panicked, right? Specifically in the workplace, and how you can really move yourself to a place of growth, and in terms of interrupting those microaggressions and really sort of honoring that space of discomfort that comes along with this, that when you are interrupting a microaggression, that you will absolutely be uncomfortable, and it will become, more normalized, that discomfort, the more often you do it. And so I would say, practice is important, and doing that sort of on your own space and time, and thinking about what is the phrase that works best, what are the kinds of situations that I've been in terms of hearing from my colleagues that they've experienced a microaggression, or hearing the microaggression itself, or experiencing it myself. What are things that I can do to really prepare myself to, just like somebody said, like having a little pocket version of this, or just a phrase that you're willing to utilize in your head as you kind of interrupt these, because that is a really important piece, is sort of honoring and channeling that discomfort that comes along with interrupting these. I can't say that it gets necessarily easy, because each situation is different. However, it does become more normalized, that this discomfort is going to be a part of this, and that you can actually move through it and continue to interrupt the microaggression. I think this is something too, that just a reminder is that, in terms of our own understanding of our growth zone, it's just really important to think about what does sort of challenge you or make you uncomfortable at work, and what kinds of ways can you really work on sort of being mindful of what zone you're in, especially when these things come up. And that's kind of for you to think about in terms of doing this kind of worksheet on your own time, is thinking about what is my comfort zone? Where are some expectations where I feel comfortable at work specifically? And in which ways can I challenge myself to be in that growth zone? And then what situations do I feel too overwhelmed? Because we know that especially in the panic zone, we often do things and say things that are actually not in alignment with our values. And actually, that's not a space to be necessarily the witness or the bystander. And that those are the spaces where we really want people to be mindful of and really be doing the work. I also would say that, if you are somebody that's told that you've done a microaggression, this is also something we haven't necessarily concentrated on, but that is something that is a part of that handout that Shiva shared earlier, is if you've committed something, a harm to somebody else, what are things that you can do and what are the expectations on that end? And I think oftentimes when we have committed something, that panic zone is pretty real. When somebody says what you did was racist, what you said was bigoted, how you handled that was discriminatory, right? That brings us automatically into that space of panic. So, that is something for us to be working on ourselves, is how do we quickly move ourselves back to a place of comfort and then channeling growth to know how best to respond so that we're not committing another harm right on top of the last. I think about, even, and there'll be a slide later on around like what to do after this training. Oftentimes after microaggression sort of training and awareness, that people tend to go back and think about the harms that they've committed and then, or apologize for them or bring it back up to Black, Indigenous folks of color. And that's not really what we're hoping comes out of this. It's really about behavior change moving forward. Because that can revisit the harm. And oftentimes we, as the one that committed it, don't actually know the extent of the harm or when the harm occurred. And so it's really about, how do I change behavior that I know potentially could be harmful based on the examples that I've heard, and how do I move forward with making sure that I'm not continuing to do that harm? I think we all come into this work, into healthcare, obviously, to help people heal, to help people live healthier lives. And, in terms of alignment with our values, we don't want to be committing any harms to anybody. And so that's a part of this work too, is just thinking about what causes me to panic, what kinds of comments or things that people say to me cause me to enter into that zone, and really trying to channel that growth zone instead. Another piece of this is this sort of idea of our ability to understand the experience of somebody else. So I wanted to share this today because I think it's really vital to recognize that we just don't know what we don't know. And that's called sort of this hallmark of intelligence, and the Dunning-Kruger effect, is that when we do that, we actually are more intelligent beings, right? And we better ourselves overall when we're aware of things that we don't know. And oftentimes when somebody experiences something, especially related to racial identity, which we can't know the experience of somebody else who has a different racial identity than us, especially if they're part of a historically marginalized community, that oftentimes when somebody says, this happened to me and it was really harmful, another level of microaggression is responding to that person and saying, I know exactly what you mean because of this part of my identity and my experience, which is just not the same thing. I think about that when I had shared once that I had experienced that comment a lot of, where are you from? And this like sort of lack of ability to hear me when I say that I grew up in Green Bay, Wisconsin, and people being very confused by that because of my racial background. And somebody said, oh, that's like, when I feel bullied because of the color of my hair. And those things are just not the same, right? That doesn't have to do with this deep-seated piece of your racial identity, and that folks who are Black, Indigenous, people of color have historically been marginalized over time. And so I think if our tendency, right, in terms of our reaction to hearing about the harms of other people is to say, oh, I know how you feel, I think what we really want people to realize is that we just don't know. And what's really needed is really sitting with people and hearing them and believing them, and saying, I have no idea what that feels like, and I'm really sorry that happened to you. And this is what I'm going to try to do the next time so that it doesn't happen again, right? So I think that's the piece that we really want to think about, is recognizing how much we actually don't know, and that means that our pie piece can actually grow. That red piece on this page is something that has wavy boundaries, and that the goal is really to push the edges of that I think about this work too in terms of taking on diversity, equity, and inclusion initiatives, you know, as the OBGYN department has been doing, and thinking about the expertise that you all bring in terms of your lens of the work that you do on a day-to-day basis, and how important it is to recognize what you do know and then create space to bring in the voices and hear the voices of the people of things that you don't know, right? And that being a really important hallmark of how we do this work, and the importance of really hearing from historically marginalized folks. So we've also had a bunch of examples shared with us of current things that have happened. And these are sort of general examples, sort of at different levels of our organization, of things that have shown up in terms of microaggressions involving patients and also colleagues. You know, sort of more recently, you know, I have pages of things that we could share, but these are sort of more generalized examples of the way that we've seen these things show up, especially right now in terms of how, you know, the Black Lives Matter movement that is going on nationally, as well as the COVID-19 kind of racialized pandemic that we're experiencing. So these are things that, you know, are experienced, and I think very, very common. And I want to draw your attention to number 3, which is, right, patients telling and attending that they don't want to have the nurse, the accent be involved in their care. Previously, perhaps people have handled this by sort of just being like, okay, and then changing the care provider, or not saying anything, and not following up with the nurse or the person that was harmed. And what we really want to encourage people to do is recognize that these are not okay comments or requests, and that is based in bigotry, right? And so really making sure to identify and name those things when they're happening is really key. And then in terms of sort of a reflective form, you know, thinking about what's the impact is really important, right? And thinking about that impact, especially if we're not the one who's experiencing it, and how might we apply strategies that we learned from those handouts to interrupt these in these situations. Because even though we've shared really firmly from the sort of patient end of things in terms of behaviors and requests, we know that these things ongoingly happen between our colleagues at work, as well as to patients specifically. And that being a really, just like they said in that video, you know, that being a really specific experience that patients don't really have the power in that relationship. And so when we know that patients are being harmed, it's really important that we kind of figure out what is the best way to interrupt that with our colleagues as well. So I don't know if there is the ability to do breakouts on this option of WebEx, but we thought maybe it would be helpful for people to just sort of spend some time thinking about examples and how might they interrupt them. Melody, do you know if there's ability to do breakouts on this? Oh,
You
If
know,
not, maybe we can open it up. The breakout is too complicated. We wanted to make sure to have time for really a conversation and as much, you know, questions or sharing of experiences, because I think having the ability to really discuss those specific experiences and situation is really, really the critical piece of this work. And I think being and I'm just going to say that's why we gave you again this kind of the comfort level, being uncomfortable with some of the answers, right? We and I you know, we all live in a healthcare setting in which I know you all know that situations, both clinically and as human behavior, are sometimes not absolute, like this is the exact path for every situation, but there is really gray areas, and becoming having that ability to talk more openly about what that does that look like on a daily basis. What are potentially the areas that are very clear and the areas that are the gray area where there is really kind of judgment and decision making that needs to happen, but really trying to process those. So Laura, I know you wanted to speak, and then we'll open it up to that conversation. You can also put it in the chat box, and we'll kind of talk about it. So whichever way you're more comfortable.
Thank you, Shiva. I don't think we could do breakouts, but this group is very used to chatting. So I think we can get a lot accomplished with that. I just want to say that as I listen to this, the thing that strikes me is that, I'm quoting someone, the piece of the pie for me that represents what I don't know keeps getting bigger. And I refuse to be beat down by that, but it's, in my view of this, is before I die. That's my plan. And I just want to say thank you, and then we'll open it up. I know Bhagavat's got something he wants to ask or chat about, and this has already just been a very, very meaningful session to me. So thank you. Bhagavat, you got something?
Thank you, Laurel. And first of all, I want to thank both Naomi and Shiva for a really engaging presentation. I have to say that there were so many times I wanted to not miss a word of this, and the nature of experiences is such that constantly my mind was going off in directions because examples and situations you can't listen to an hour of a talk of this nature without reliving your own personal experiences and thoughts. So I'll apologize beforehand if I have missed something and I'm bringing up something that you had addressed. I have two specific things, and I'm going to bring the second one second because it may touch a nerve in you, and I apologize for that in advance again. To give a little background to you and to the rest, I grew up in India. I am Indian, Asian Indian. I went to the UK for training and initially spent time in England, where I never experienced, weirdly enough, any racism, either at work or outside. Then I went to Scotland. By now, I had been experienced. I had lived in England for 2.5 years. I was not so much of a transplant. I was beginning to be a little bit more local. And I experienced racism both at work as well as outside. It was a shocking revelation to me at that point. And when I came to to US, I experienced racism both at work as well as outside. Particularly New Hampshire, my wife and I decided we'll never go back again. This was experience outside of work. It's just, I think, something that we lived through, most of us who are not white, if I can say that openly and clearly. But I also feel that I have been incredibly protected and sheltered, uh, either because of my standing socially here in the US as a doctor, and also my affluence, because those few instances, and I'll be honest, they are few, I can count, I relive them, they are very vivid in my memory, or just few that I can count on my fingertips. I feel for all the Black people who live that 5, 20, 30 times a day in their life. Um, so, having given that background, I have two questions. One is the policy that came out. I know it's been a labor of agony and love over the last 2 years, from what I hear from Dr. Rice, and it has gone through many, many revisions from what I hear as well. However, there are certain clauses in that which I feel are at odds with the message given over the last hour, particularly the clause 2D, which all of us have struggled with because it is so at odds with the rest of the document. And secondly, as OBGYNs, we do not unfortunately have the luxury of going through that workflow of do this, if that, do that, because it's frequently a very almost life or death situation, especially on labor and delivery. So again, we need to have some clarity in exactly how we are going to deal with emergent situations when we don't have the usual ability to reflect, call people, reason, etc. The second point I want to bring about is this is where my mind was going at 1,000 knots an hour. When you talked about how we're going to respond to patients who will not accept certain residents or fellows of color to be involved in their care, or nurses, for in the example that's on the screen right now. And my mind is like, I will be honest, I was partially listening to you. I'm like, but I am the black or brown doctor. If I am the person, if I have two white residents with me and the students, and the patient is saying that she doesn't want to be taken care of by myself, what do I do? And I can tell you, I have already faced one racist situation in this institution myself, not from the patient, but from the patient's husband. So I can see this happening. I can see it happening time and again until I retire from work. But I also honestly expect the institution to be supportive of me. And I look at this document and I feel let down. These are very respectful. And the second point I raised about you talking about as though it's a white attending that has a black resident or medical student who is being discriminated is how I felt in your examples and how to deal with. It was not addressing what if the attending himself is black or brown and is discriminated against. How are we going to deal with that situation? So if I have misrepresented what he said, I apologize. But this is how I am listening to this as you spoke. Thank you.
Thank you so much, Vala, and thank you for sharing your experiences with us, which we deeply appreciate. And what you described as your experiences are indeed what, unfortunately, we hear about often, and actually what this policy is set up to protect you against and to set up our values around. So from our side, apologies if the examples, again, they're just meant to be different examples, but certainly the fact that attending, just like yourself, are the ones that are being told that by the patient that they don't want the attending, but prefer, for example, a white resident, absolutely also part of the experiences and the examples that we hear. So I'm just going to try to address a couple of your comments, and then you tell me if I'm still not address them in a clear enough fashion. So I'll start with the second one. A patient refusing an attending based on bigotry, based on our policy, the overall statement is that is not okay and not acceptable for us as an organization. Now, just like as I was saying, there is a couple of nothing sometimes in I would say in clinical care and in healthcare and dealing with people is always just absolutes, right? So the gray area of there is the following. If you as the attending feel that this situation is really not allowing you to have a good therapeutic relationship with the patient, is triggering to you, doesn't allow you to feel like you're able to really do your best, it gives you the opportunity, if this is a safe thing to do for the patient's care, to say, you know what, I prefer not to be in this situation. So it really empowers you as our faculty and providers to decide, again, if the situation from a patient's stability and safety allows you to do that, to say no. And we have had, and the reason that we allow that is we have had actually attendings who have said, I just cannot continue to be going in and seeing this patient. And again, those have not been, it's been inpatient, but it's been like a patient that may be on the unit for a week, right? I just don't feel like this is a good situation for me. Is really wearing down on my capacity to really function very well because of how the patient is behaving. And that could be after we've even tried to address the patient's behavior. It's been in one of the situations, a patient who really honestly had dementia, but was using words that were extremely triggering to the attending. So one, it gives that ability, and we want to, we wanted to make sure that we do that. Again, empower the faculty and staff. The second piece that it does is that it says we are going to let the patient know, no, we're not going to be accommodating unless there are, in your best judgment, reasons in which it makes sense to do that. And those reasons are described, and I know this is going to probably seem again great. Those reasons are described as some form of trauma by the patient that you are able to assess. So if a patient is being, again, you cite in the example of the video, we can assess that this patient is having some form of PTSD or some form of trauma that is coming up, that we would do always what seems to be the best course of action for the best care for that patient. And if the request, again, is around cultural concordance needs that meet our cultural concordance or culturally and linguistically competent care, again, always within the circumstance of the ability to do that based on the clinical needs of the patient. So if it's emergent and it's urgent and we cannot do it, to say that we're not going to be able to accommodate because we want to take the best care of the patient, that is okay to do. I would just encourage us to make sure that, as I said, we need to practice how we do, we respond to macroaggression, that we also all need to kind of take some time to practice. How is it then we have that conversation quickly with the patient to say, at this point in time, I am the attending, I'm the only attending that is available. Your situation right now, baby is ready to crown, and I am the best person and the only person that's available right now to take care of you and your baby in the best way possible. If you do not allow me to take care of you, that would, we would have to talk about a refusal of care. But again, doing so in an empathetic, in a way that tries to really approach the situation in trying to resolve it. Not, this is it, I'm it, and you are, it's me or nothing, and I'm just, and I'm having a conversation that is antagonistic in the middle of labor and delivery. And I trust most of you know how to do this, but I just have to say it out loud that that's the conversation that needs to happen. And I'll use this example because oftentimes, again, we hear like the patient refuses, again, in a, clear situation in which, again, I will use OB clearly, that, baby's being born, the patient is saying, no, I can't have a male in the room right now doing the delivery. And there is no other option available to have an empathetic conversation about why you are the best person and why it's really important for the health of the patient and the health of the baby for you to be present and do this delivery. The majority of these situations also, and this is, I know, a conversation that is being had as far as like developing some internal guidelines within OBGYN. If we can have this conversation as early on as possible with our patients and families, it's really great. And again, I'm not saying 100% of the case that's possible, but for those patients, for example, in OB that we're following in prenatal care, being able to really set the parameters for them about what their expectations should be at the time of delivery and who they should expect as far as the diversity of our OB group in delivery, and making sure that they are giving their understanding and consent to that is really important. Bala, was that responsive to your question? Is there any other? I don't want to muddy it, but
No, thank you. And I don't want to monopolize this
no, that's
chat as well. I'm sure others would like to ask their own questions. But thank you. I appreciate all that extra effort in explaining. And I still am concerned when you say culturally, right? What does that mean? Can a white person say culturally, I don't want anybody black to touch me? Because it's a very I've tried to Google that culturally sensitive. It's a term that is new to me. I just want to make sure that see when there's no policy is sometimes better than a policy that actually states something like that in black and white. So when they say culturally sensitive, then it's subject to so much interpretation that I am very worried that that will still be held against me.
yeah. And so again, I mean, I just want to make sure that to refocus on saying that this policy is not intended to hold. This policy is intended to again to protect actually faculty like yourself, Bala, not to hold anything against. And it really does give, just like any of our policies, there's still going to be best judgments and reasonable judgments that are going to be made. This is why you are all MDs and professionals in your world, and so there is a level of I think professional judgment that is expected. Naomi, I don't know why, but that I can't read it at all. Can everybody else see that, or is it all muddy?
Oh, is it all muddy? Here.
Yeah, why?
Okay.
So to
Better?
answer your question, Mala, about that's much better.
Okay.
So we do have actually definitions. Culturally and linguistically appropriate care is actually a term that is used in both federal government requirements of how we provide care to our patients and also in Joint Commission accreditation. So I do want to point out that it is not a term that like we've kind of come up with but it is really a term that is used in expectations of the type of care that's provided. Now, I understand that people could define it very differently, but I'm going to go back to what we said at the very beginning, which is the whole intent of this is around communities and people who have been historically marginalized and have not received the type of care that the type of care and equity in care outcomes. So that was also the intent of the use of those terms, and they need to still reflect our values. So our values are around respecting culture when it's really a value that is deeply seated in that culture. It is not, and I'll just be for those of you who don't know me, I'm very direct. So it is not part of our values to uphold white supremacy or say that that's a belief system that we are going to be supportive of. It is part of our values to say that Muslims are a large communities around the world, and that they do have values that are really deeply seated in their cultures that have to do with modesty, and that again, in our best of abilities, we're going to try to be understanding of those values and have systems and ways that we're going to be able to be responsive to beliefs that meet our values. But certain values that are just not part of our cultural competence because they're one, for example, white supremacy. I mean, some people may think it's a culture, but it's not a culture. So again, it's intended to be for those communities who oftentimes have not seen their values of their culture, which are actual real cultures, to observed and respected in a healthcare setting. And again, we're not saying we should 100% of the time accommodate anything. We're just saying we should just be cognizant of those and try to be to accommodate if and when possible and when it meets our values.
Thank you. I'm going to stop there and let others take care. But maybe the last line you said, that has to be part of that document, that this is meant to be as much as possible. It's a guideline. It's not absolutely applicable in 100% of the situations. I think maybe that making that very, very crystal clear in the document would be maybe put people like me at rest and make us less troubled by what is in there.
So thank you, Bala. I also noticed there's a comment in the chat about concerns that this policy could be used, right, to sort of continue to marginalize and discriminate against providers and folks who are Black, Indigenous, people of color, and sharing that resource. Thank you for sharing that. I think part of it, right, is investigating the root of the request. So if somebody says, I only want a white provider in doing my care, I believe that's culturally concordant or culturally linguistically concordant care, appropriate care. Really investigating further if there is time to say, why do you have that request? Why do you believe that there is sort of this cultural background related to that request? And actually, oftentimes it'll come up, right, really clearly that this is a racist request. So, I think not just leaving it with the first statement if there is time. If there isn't time and it's an emergent situation, that's the space to really use some of those phrases. UW Health is committed to being a diverse and inclusive environment. We don't choose our providers based on race. That we really celebrate the diversity of our providers and our staff, and everybody who works for UW Health is here to provide you with excellent care, right? So I think, again, sort of stopping that comment in that way too.
And I'm going to be also very honest. White people have made choices about having white concordant care for a very long time with us as having a policy and an ability to protect our BIPOC providers. So the intent of the policy is the opposite. I challenge you to know that white patients have had a choice. They have made those choices for a very long time. One, because the majority of providers have been white. So without even having to speak or say anything, they have had that choice. So this is intended to be the opposite. It's intended, again, we don't know the intent until we know of a patient, So I'm not also saying that patients who make those choices without saying anything else, they go look at our website, they make choices of who they want as their providers. Unfortunately, like, we don't have control over those things, but we do have control when they're either speaking it or they're making it clear that their choices are based on bigotry. So that's that is, the thing that we need to think about, that this elevates us to be able to have a conversation with the patients when they are speaking it, to say, no, that's not okay. Because again, patients are calling sometimes and saying, just to make an appointment, I don't want any ex-doctor, and I don't want any doctors with an accent, etc. And that this policy now gives us the ability to say, at UW Health, we are proud of the diversity of our providers. That is not, a choice that we would accommodate against. And so there is a comment about religious ideology. So religious beliefs are actually part of people's culture. What we're saying is women, for example, have made choices of selecting women as their providers. I think that's just something that has happened. Men can make choice to select men as their providers, so it's gender based because of concordance. Again, we're not saying at a time of emergency, at a time where things are, the accommodation is not possible, that we are going to say 100% we're going to accommodate. We're saying if the reason for the request is based on a concordance or cultural belief system, that we will be respectful and try to be responsive in dealing with the belief system. Again, I think it's really important for us to really consider what we think of being, belief systems and as opposed to kind of ideology. So there is a question, when a patient requests a female provider when scheduling, should you honor the request rather than saying, well, are you requesting a woman? Yes, I mean, again, if people are calling in and saying, I want, I prefer a woman provider, which has been going on since a very long time, we would say, okay, if a woman provider is available, yes, but what we're not saying, and I think that's been part of the conversation, we're not saying we're going to overbook, we're going to do things operationally that does not make sense to do because there is that request. So if, for example, if a female provider is not available within a time frame that this patient needs an appointment, our response would be, we do not have a female provider that's available. The only provider that has maybe open appointments is a male provider. Would you still like an appointment or not? And then the patients can decide whether they want an appointment or whether they want to seek other options for care. So it is not meaning we're gonna overbook, we're gonna it means, yeah, we don't have somebody available. If you do not want, here's the option that's available to you. I'm checking the chat. Other comments?
And I think just a reminder too that this is around folks that have been historically marginalized. So, I think that that's a really important piece, is just centering those voices. So, if that's a part of that scheduling piece too, if somebody requests a Black provider, you don't need to ask the question why if there's a provider available that represents that identity, racial identity, because we know that historically that hasn't been the case, and the ability, just like Shiva mentioned, and that is cultural concordance of care, right? And that we know actually based on research that the similar racial identity, especially for those who have been historically marginalized, there are better outcomes when it comes to care. So that is also really an important thing just to remember as a part of this policy.
Shiva, there's something from Katie Sampine in the chat box.
Did I miss it? I don't see it. Can you read it for? Oh, I just saw it. The flow chart?
Yeah.
So again, this has been a conversation back and forth about the flow chart. The flow chart was intended to kind of provide additional support for decision making, and I think in many ways, it's maybe created some kind of misunderstanding of the intent of the policy itself. So for that, I do apologize. It's a supporting document to the policy. So it gives the option to accommodate. It doesn't mean you have to. It gives the option to accommodate. And again, I'm just going to pose this situation. It is the situation in which and the intent of it was, if the provider absolutely feels that they just cannot do this is not a good place for them to be right now, to be providing care for this patient, and they can accommodate. They can, based on the medical condition and also on the availability of another provider to assist them. So I'm just going to give this example. Again, if you are supervising a resident, you're the attending, and the attending, the resident is really being absolutely like saying, can I not be the resident here because this patient is really, their behavior is really making me feel like I can't do a good job, that we're allowing that to happen again within all the other circumstances for the decision making. So there is nothing that we're going to be able to put in a flow chart that's going to be able to be 100% at any time. I'm going to say it again. I want to make sure that you understand that the expectation is that you would use your best judgment to make a reasonable decision at that time of an emergency. And I, for one, think that you do that every day, all day, with a lot of things. So again, that is always there and available to you. It's just, it was intended to provide you the best guidance possible.
So, Viva and Naomi, it's Ellen Hartenbach, and I'm really appreciative of all your comments this morning and the training that you did in August. And I think the UW Health's intention is to try and root out discrimination and bigotry among patients and against providers and against patients and these two large groups of people. And so if I'm reading the policy is really to try and prevent discrimination and requests for providers for personal characteristics. And so what you're trying to tell us is that you want us to accommodate, but really, if it's not possible, putting in the clause that we may accommodate is really your way of saying we have latitude in these situations and that we ultimately can use our best judgment. Is that what it's really trying to say? Because I think people are getting caught up on the clause where we may accommodate, when in reality, in emergent and time-sensitive situations, particularly obstetrics, we really cannot accommodate.
And if you cannot, you cannot. Again, it's giving you're absolutely correct, Ellen. We're giving latitude because you may decide you cannot, but we want to give that latitude that you also may be able to.
So it's your way of supporting providers.
It is the entire intent of this policy is to support providers who have come from historically marginalized backgrounds and who have not been able to feel supported, while at the same time making sure that we do not, as an unintended consequence, have our patients who come from historically marginalized background not also get the care that they need. So
thanks for just clarifying that. I think that's helpful. It's very, very difficult policy to write.
Yeah.
It sure is. Laurel has lived through it. But again, I think, and my understanding is that there is some, guidelines that are being worked on that will hopefully maybe further clarify again within OB-GYN, which I understand. The other thing that I want to point out is that, again, policies are for the entire organization are intended for to cover everybody, right? Everybody in every situation, ambulatory, inpatient, OB, but a whole lot of other services, right? So I think, the ability to really have this more localized conversation about what does it look like really, again, in an OB situation, in an ambulatory situation versus an inpatient situation, within your kind of your own department. It's certainly something that we support and want to be supported, because we understand that policies can be very just in a way very, very broad, because they're trying to cover everything in everybody in the entire organization, from all services, all departments. So
Shiva, this was very helpful, because that one little discussion that Ellen just brought up is in large part the crux of it. And I'm speaking for the whole department here, what we want to make sure in those emergency situations, if our individual decision is that we cannot accommodate, does UW support us? And because there's all that emergency thing, and I mean, not that I'm prejudiced, but every member of this department, physician and otherwise, I mean, an amazing group of people. Of course, this thing of understanding where people come from, which is what this is all about, but it's that gray area where there is not a woman to deliver this baby. There is not a white person to deliver this baby. You know, this thing of feeling supported for UW, from UW, is just really important.
yeah, and so the quick answer, Laurel, is yes, we would. What I said is correct, that if you cannot accommodate, you cannot accommodate. I think the expectation is that, again, as I said, that you would have as quickly and as much of an empathetic conversation about why and how, and that you would use your best judgment too, right? Like, can you really not accommodate? Does this call even for even trying, right? And it may not, but is there some particular issue going on in this situation where you may try, right? So again, the patient just discloses that it's just based on, just gang raped and sexual trauma. Can you would you consider it? Maybe, again, it's giving you that as an option of a may, but that if you cannot accommodate. But again, the expectation is that you will try to have as much of a empathetic conversation to explain to the patient why. And again, I trust that that's kind of what's happening. And I also trust that in the majority of the cases, that conversation happens much earlier on. Hopefully, again, if like in majority of cases, we are actually have seen this patient before their delivery. And in the majority of the situations, for the patients that we deliver babies for, they have had prenatal care with us. So again, early on, having those conversations, making sure people are comfortable and understand who we are, what the diversity of the attendings that we have and what they should expect, and arriving to agreement. If they disagree and we're not the right place for care for them because they don't want the diversity of attendings and people in delivery, they can make choices to be in other places, right? And so, yes, to your answer, Laura. I hope that's, and then does Merida Hospital have the same policy? Merida is working on finalizing their policy. So they do not have a policy in place yet. Assistant Health did recently finalize their policy, and it is kind of very similar in its intent and kind of ways of talking about this than ours. So Merida is finalizing their policy, and hopefully it'll be in the next month or so. We certainly have shared our discussions and our policy with them. So we're hoping that they can finalize theirs. One thing that I want to also say, just on the positive ending to this is that there, in the Council of Chairs, which Laura was leader in these conversations around, there was also a conversation about how do we make sure that we actually externally express to the community, just at large, not individual patient, but the community at large, our value as an organization around supporting our faculty and staff of color, and just so that it's just like we're sending that message out to the world, like here's who we are as an organization. We are a diverse organization, proud to be so. And so if you're going to get care here, expect that that's who we are. And so we're working actually in kind of a communication plan around that externally. It may look like a letter to the editor from Dr. Kaplan and Golden. Actually, Damon Boatwright from SSM Health had contacted us to say that we should have a joint, actually, like saying these are our values as just all health systems in this community, which I think it's a great idea. So we're working on that so that we can, again, just very broadly and clearly make sure everybody knows we're not going to, we are organizations that have values of diversity and inclusion, and we're not going to tolerate bigotry towards our providers or staff.
Hello? Could I ask a question?
Go ahead, Laura.
Well, what I'd like to know is, as we have such a diverse population of students and residents, are they informed of what you do if they feel that they have an issue with it? Do you present this sort of stuff to our new residents and students?
Thank you, Dr. Sarker, for that question. Yes, we have started to present this information to them, both in new resident orientation and also working with the GME office. We're trying to really up our effort to make sure that our residents really clearly understand that we have these kind of policies in place to support them. So we've been doing a lot more with residents and fellows. I think you raise a very good question as far as the medical students. We have done some of it, but I wouldn't say we've done it in a systematic way. So I'm going to take that as a takeaway from you, Dr. Sardo, about how do we maybe partner more with the School of Medicine and Public Health to make sure that the medical students who are going to come into our clinical areas are aware of this policy and, again, our value to make sure that we support them. So
thank you.
Thank you.
I think another thing to highlight too, and I know we're coming to an end here in terms of time, and I want to be mindful of everybody's time today. This has been such a good discussion. Is, I think there's been a lot of questions about, what are some good resources, or how might we have these really difficult negotiating discussions, especially when gender arises. And I think that is a really good identification of maybe a process improvement in terms of OBGYN specifically. I can only, respond from my own experience of having a baby and delivering and having an OB who was on call do the delivery when it wasn't my, primary OB. And that was never a conversation. I was told that there might be residents assisting, but I wasn't, obviously we know that there is racial diversity, gender diversity, et cetera, within each department within our healthcare system. But I think that part is key, especially within your department, is thinking about how do we have, just like she was saying, on the front end of recognizing that if there is an emergent situation, these are what the options will be, right? We have male OB-GYNs on call. We also have female OB-GYNs on call. We also have residents who will be there as well. We celebrate diversity within UW Health, so there will be people with other racial backgrounds. We just want to let you know that this is the case, as you do move towards your delivery or your due date, like these are the things that might be coming up. Do you have any questions or concerns about that, right? And I think really sitting down and just verbalizing it might be also something that allows, at least, you know, when the patient is not in a situation where they are kind of in the stress of labor and delivery in those moments, where they're able to sort of contextualize and understand what it is they're moving towards, because I think that that is a place where maybe in terms of process that can be added to the process if it hasn't already. I think work in these environments, we forget that not everybody's aware of how those things work, right? In terms of the process of what it looks like when you actually end up going to the hospital, and that those things are really, like, you can't plan for when that's going to happen. So I think that might be another thing to think about as your own sort of department, is like, how can we improve this part of the process on the front end, right? Thinking about, you know, really being preventative, so that we're not in those emergent situations and having to make these like really gray area choices, where people as providers as well as patients are really at the table and making those decisions, right? And being really informed. So I think that might be another thing, is to really think about how do we improve this part of our process and really give patients an understanding of what this looks like, you know, before it's happening and in the moment. So I know it's 9 o'clock. Yeah, we are at time. So, you know, thank you so much, everyone, for your comments, suggestions, thoughts. This has been a really powerful conversation, and hopefully helpful as you move forward with implementing this policy. And I think always coming back to the piece around the experiences of microaggressions, not only with patients, but also in terms of our workplace as well, and what we can do as bystanders. So thank you, everyone.
Thank you. Thank you
Yeah,
so
thank you
much.
so much.